All right, so I will be doing my presentation on somatic symptom disorder. The DSM-5 criteria are 3 criteria. So for criterion A, 1 or more somatic symptoms, so bodily physical symptoms that are distressing or result in significant disruption of daily life. Criteria B, excessive thoughts, feelings, or behaviors related to the somatic symptoms or associated health concerns as manifested by at least one of the following. Either disproportionate and persistent thoughts about the seriousness of the symptoms, persistently high level of anxiety about health or symptoms, and excessive time and energy devoted to these symptoms or health concerns. Criterion C, although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. So what this means is that a person might have, let's say, chronic headaches for 2 months, then those headaches go away, but in place of those headaches, they have, say, chronic back pain. So as long as these symptoms persist for 6 months, they would still meet the time criteria element for this disorder. Then some specifiers, there's predominant pain and persistent. So with most somatic symptom disorder presentations, pain is present. And then persistent just means that the symptoms have been present for 6 months or more. Then for severity, there's mild with just one symptom from criterion B, moderate 2 or more symptoms, and then severe is 2 or more symptoms with multiple complaints or one very severe somatic complaint. For the differential diagnoses, there are first and foremost other medical conditions. So with somatic symptom disorder, there's ineffectiveness of analgesics, often a history of mental disorders, persistence, and stress. Because somatic symptom disorder does deal with physical symptoms, other medical conditions definitely need to be ruled out before this diagnosis can be given. There's also illness anxiety disorder, which is very similar, except for with IAD, there are no symptoms present or the symptoms are very minimal. Functional neurological symptom disorder or conversion disorder is the perceived loss of function of for example, of a limb. So while that limb is still present and doesn't seem to have any neurological reason why it wouldn't be functional, the individual believes that they don't have function. Delusional disorder, the client's conviction of the serious illness is elevated to delusional levels. OCD, the intrusive thoughts exist with compulsions to reduce anxiety, but in somatic symptom disorder, while there are intrusive thoughts and they're disturbing, normally the compulsions are not present. Factitious disorder and malingering, there is an intent to deceive. So similar to illness anxiety disorder, there are no symptoms, but with factitious disorder and malingering, the symptoms are completely made up, and an individual might do this, for example, to get government assistance. The other differential diagnoses are panic, generalized anxiety disorder, and body dysmorphic disorder. Some common comorbidities, for sure, anxiety and depression. That accounts for 50% of the comorbidity. So with somatic symptom disorder, it's very, very common to have people present with either both and or anxiety and depression. Also, like I said previously, general medical conditions can be present. So the degree of impairment is marked more than just the physical illness alone. So someone with somatic symptom disorder, they might have a complaint, but that complaint is really exaggerated in comparison to how much pain or disturbance that physical complaint should cause, like a normal presentation of the same somatic complaint. PTSD, criterion A events can leave the client with physical symptoms and or pain, but just like with the general medical conditions, this is very escalated. Then OCD can also be a comorbidity, and sexual dysfunction in men. So with these comorbidities, it's important to know how to rank the primary diagnosis. So what is the person's complaint, their primary complaint when they present to treatment, and what is causing them the most impairment or loss of functionality in their life. Okay, so a little bit of history. Somatic symptom disorder used to be called somatoform and related disorders in the DSM-4, but this was thought as maybe too vague of a diagnosis, or perhaps this was getting overdiagnosed in the general population. So the prevalence in that general population is about 4 to 6%, so not very high, but you'll see the percentage jumps a great deal in primary care patients with 10 to 20%. The diagnosis is higher in women, and some contributing factors to the diagnosis or biological and psychological vulnerabilities are neuroticism, the presence of anxiety and depression, which is about in 50% of the cases, lower education levels, and lower socioeconomic status. Impairment, with this disorder, there's high psychological distress and marked impairment. In children and adolescents, this can be seen with a lot of school absenteeism, and for everyone, higher healthcare costs. For impact on others, I looked at one study in Italy done during that first COVID lockdown, and it was seen that somatic symptom disorder really impacts relationships with parents. Those relationships were seen to suffer, while relationships with peers improved. Now, impact on others, it's really going to be family or close friends or relatives and caretakers, because often these people with these somatic symptoms perceive their symptoms to be really really severe, and so sometimes they're homebound, sometimes they can't work, so they are thrown together a lot with their family and caretakers. As a result, these individuals have perceived burdensomeness on the family, thwarted sense of belonging, especially if they can't work or they can't achieve the same milestones as their peers. There've been seen to be a lack of trust. Maybe people aren't believing their symptoms. So this is family and primary care physicians as well. Increased depression and anxiety, and also suicidality. Now, when someone is not treated for this disorder, most likely it is not going to resolve on its own. So there's no real cure. When we think about the treatment of this disorder, it's really just the management of the symptoms themselves. Another result of disorder without treatment is that clients will likely utilize their healthcare resources or overutilize the resources in an attempt to ameliorate their symptoms or find the root cause, and thereby they most likely will experience financial distress. The causes of somatic symptom disorder are considered to be maybe physical. So if there was an injury or chronic pain resulting from an injury, an individual might hyper-focus on that pain or injury and believe that it's more severe than it actually is, or they're never going to get better. It might be idiopathic, so just arising out of the blue with no known cause. And there was a German study I looked at that it was thought that burnout or work burnout and stress could be a cause of somatic symptom disorder. The psychiatric causes were thought to be sensitivity to negative emotion. So again, that neuroticism and decreased trust of medical and psychological professionals. Some maintaining factors. This disorder is very cognitive. So catastrophic thinking styles, symptom focusing, and perceived burdensomeness. And there was a study with a 4-year follow-up. So after treatment, these individuals were followed once again, and 30.4% of them persisted with their symptoms of somatic symptom disorder. So it's pretty difficult to treat. And the reason why it doesn't go away on its own and it's difficult to treat is because it persists due to distress and anxiety, and can be negatively reinforced by these frequent doctor visits, and also reinforced by the attention that the individual gets from the healthcare system. So, for example, if the person is not receiving that the care from their family that they want, and they're receiving care from the healthcare system, they might seek that out over and over again, which would negatively reinforce the importance of their symptoms. Oops. Okay, for empirically supported treatment, the best treatments available are exposure-based CBT. So this focuses on the maladaptive thoughts about the individual's illness and pain to modify the client's emotions and behaviors. So it's an attempt to refocus the client away from their situation, which sometimes they perceive to be unchangeable. It's an attempt to be flexible and expansive, especially with chronic pain. And then also this CBT and exposure attempts to identify the client's strengths as well. Family therapy is also recommended for SSD just because it does affect the family. And there's another treatment in one study that I found called emotional awareness and expression therapy, and this was done online. There were significant results from this study, but I don't think that it is very widely used. I think the exposure-based CBT is really the gold standard for somatic symptom disorder. So in addition to therapy, there are also pharmaceuticals that can be used. SSRIs, especially for somatic symptom disorder and body dysmorphic disorder. SNRIs are more effective for the treatment of pain. Tricyclic antidepressants, atypical antipsychotics, and herbal remedies are also used. So when we look at these pharmaceuticals, we might think, well, those are typically treated for anxiety and depression, right? Well, there's a 50% comorbidity there. So this rings true that these would be the types of pharmaceuticals that would be used for individuals with this disorder. Also, as clinicians, cooperation with primary care providers is recommended for us because it's very, very common that these people will be frequently seeing their primary care providers as well as seeking out therapy. So if we can collaborate with their primary care providers, that's going to help to elicit the best treatment we can for these individuals. And then lastly, there's no evidence of gender differences in response to therapy or pharmaceutical treatment. I did find an assessment for somatic symptom disorder because it can be a very tricky differential diagnosis. It's called the SSD-12. And so there are 12 questions on this assessment, and it's broken down into a 3-factor analysis of cognitive, affective, and behavioral symptoms. So for example, one of them is, I think my symptoms are a sign of serious illness, and it's rated from never to very often. And then lastly, just to conclude, someone with somatic symptom disorder, their suffering is authentic, whether or not it is medically explained. So there's going to be a need for empathy and understanding here. And also that's a huge clue as to how we might differentially diagnose somatic symptom disorder. And these are my references. Thank you very much.